Melvin said, my name is Harry Mond. I live in Melbourne, Australia, and I'm delighted to have you spend your lunchtime with me. So we may be calling that in the future, Lunch with Harry. Today, I'd like to talk on the spectrum of ambulatory ECG monitoring. I have been a cardiologist for over 50 years, and I can remember back maybe 45 years ago when I first started reading Holter monitors, and I've watched the whole ambulatory ECG monitoring evolve over the years. And today there's been vast changes in recent years. And indeed, probably at the end of this talk, there'll be more changes, which I will not be aware of. Ambulatory ECG monitoring is a valuable investigative tool for patients with symptoms thought to be of cardiac origin. Historically, there are three methods of ambulatory ECG monitoring. There's the short term, which is the Holter monitor, generally 24 hours, but up to 48 hours, but today has been extended further. There is the medium term event monitors, which do not do continuous ECG monitoring, but rather only record events, and that can be up to 1 month. And finally, there's the long term, maybe up to 3 years, implantable loop recorders. The way this is involved today, though, is that there is considerable overlap in these three, and in particular, the short-term Holter monitor has now become a medium-term form of monitoring as well. The basic indication for ambulatory ECG monitoring is arrhythmia recognition. The ACC/AHA guidelines, which are back as 1999, but are still relevant today, calls a class 1, that is, it's been proven that Holter monitoring or ambulatory ECG monitoring is useful for unexplained syncope, near syncope, or episodic dizziness, and in particular for unexplained recurrent palpitations. Let us look, therefore, at some of the indications, and as you can see here, it is basically arrhythmias we're looking for, and you can see a long list, and I'm not going to talk about all of these, of course, but only a small number. And the first, and by far the most important, is cardiac palpitations. Cardiac palpitations are the most common indication for ambulatory ECG monitoring. In almost all cases, a Holter monitor is the initial investigation, even when the palpitations are infrequent, in the hope that they will capture an abnormality, even if asymptomatic. It's also the most common indication for medium-term event monitoring and is now becoming established for long-term implantable loop recorders. I'd like to stress, though, that a symptomatic negative test, that is, a test that shows no abnormalities, but if the patients are symptomatic with recurrent symptoms such as palpitations, the Holter or ambulatory ECG monitor is diagnostic and even therapeutic in that the patient can be reassured that there are no abnormalities. Here is some of the ECGs that we look at when we're doing monitoring. This is atrial fibrillation, and we in particular like to get the onset and the offset. Supraventricular tachycardia, once again, onset and offset. And here we have something that is very, very common in almost every case. We see a little run of a faster heart rate than the sinus rhythm. It's usually less than 100 beats per minute, and we call this a supraventricular run. It is of no consequence, no importance, but it must be differentiated from sinus arrhythmia. The important finding on a Holter monitor today are ventricular ectopics. If they occur in groupings such as bigeminy, trigeminy, couplets, we call this ventricular ectopy. Now, on this ECG, you can see single ventricular ectopics and then a group of three, which we call a triplet. Holter monitors are very important in diagnosing this, and we have to understand how to interpret the results, because ventricular ectopics are frequently asymptomatic. They occur at all ages. They're more common in the elderly, and on a routine ECG, it's approximately 1% in males. A Holter monitor, however, from 18 to 45-year-olds, it occurs in 41% of Holter monitors. And if you have an older group, then it is 73%. No structural heart disease, then it is very rare to have more than 100 per hour, which is 2,500 over a 24-hour period. It ranges from high burden and asymptomatic to low burden and very symptomatic. So some patients can have a huge number of ventricular ectopics and not feel them, whereas others might only have a handful but are very symptomatic with it. In the absence of heart disease, they are of low risk. Structural heart disease, though, is another matter because it's more sinister, particularly in regard to sudden cardiac death. We usually pick a figure of 24%, which we call high burden, that may lead to ectopic-mediated cardiomyopathy. That means the ventricular ectopics are involved in causing left ventricular dysfunction. This figure, of course, comes from the literature, but sometimes in certain vulnerable people, a much lower burden may be responsible, whereas in others, a much higher burden may not cause any cardiomyopathy at all. What is important, however, is that a cardiomyopathy is reversible following ablation of these ventricular ectopi. The next indication for ambulatory ECG monitoring is unexplained syncope or episodic dizziness. Generally, the Holter monitor has a low return, but unless, of course, the patient is having these turns very frequently. Irrespective, though, it is usually the initial investigation. And on the findings, as I will show you in a moment, asymptomatic features on the ECG may be clues that are very helpful. The medium-term event monitor is very valuable. However, there must be an automatic loop recorder for syncope. That, I mean, that the event monitor recognizes asystole or whatever other cause and will document it, because there's no value having a event monitor that you have to press the event button if you have syncope. And finally, long-term implantable loop recorders are very useful for infrequent syncope. Let's have a look at some of these cases where you see a clue on the Holter monitor. Here we have sinus arrest for 4.6 seconds. This is overnight, but it may give you a clue as to what is happening. Similarly, we have got complete heart block and ventricular standstill for 3 or 4 seconds. It too gives you a clue. Then another indication for ambulatory ECG monitoring are suspected slow heart rhythms. A Holter monitor provides a 24-hour window of heart rate changes. And you can correlate that to symptoms. And if you do have significant bradycardia, you may consider a pacemaker. If not, repeated studies may be indicated, whether it be 6 months or a year later. Clearly, medium and long-term monitors have no value in suspected slow heart rhythms. And the important one that's getting a lot of attention today is cryptogenic stroke evaluation, called neurocardiology or cardioneurology. Here, the neurologist plays a significant role in ordering these monitors. That is because 25% of ischemic strokes remain unexplained. A stroke of unknown cause is frequently due to silent paroxysmal atrial fibrillation, particularly in the elderly, and they will all require, of course, anticoagulation. A Holter monitor is valuable, but preferably multi-day. An event monitoring has very low return because the patients are asymptomatic. Although I must say that today companies are developing event monitors which can document atrial fibrillation. And then the implantable loop recorder, which is becoming very helpful in this group. Finally, I'd like to have a short word on non-arrhythmias. There are a list here of different reasons why we might order our ambulatory ECG monitoring in patients who do not have arrhythmias. Now, all of these have got software available within the monitors, but there is no established indications whatsoever for any of them. I would, however, like to mention one. It's ST segment analysis. Here we can have a look at a Holter monitor and we can see significant ST changes. Now, these are not unusual even in the young and in patients who have no symptoms. They don't usually mean myocardial ischemia. However, in the presence of chest pain, particularly if it's recurrent, you can see this, then this is essentially a positive exercise test and action must be taken. What about the hardware for ambulatory ECG monitoring? Well, the short-term Holter monitor was developed in the 1950s. It was suggested by Paul Dudley White, who was known as the father of cardiology, an American, and he suggested to a physicist, Jeff Holter in Montana, to develop such a machine. And you can see on the right where Jeff is got a Holter monitor on the back and he's on a bicycle. The early models were almost 40 kilogram. And they had a radio transmitter and a receiver. And if you wanted to analyze the data, it took the same time as recording. So if you recorded for 6 hours, it took 6 hours to actually analyze it. A few years later, 1962 was the first commercial production, and these used small portable tape recorders. They were smaller, lighter, and most certainly quicker to analyze. And we could have 2 channels over, I say, about 10 hours of recording.